as a result of the Senate Committee, the Quality End-of-Life Care for Every Canadian, the report that came out in the middle of 2000, as a result of that, a strategy was launched to address palliative and end-of-life care. And in Winnipeg, in March, about 120, 130 people from around the country came together to launch this strategy. So this strategy has got many components within it. There is an end-of-life care coalition, and the Canadian Hospice and Palliative Care Association is leading this, bringing together these stakeholders, these national stakeholders, including organizations such as the CAS, the Canadian AIDS Society, etc. Bring this coalition together to become a very powerful coordinated voice for palliative end-of-life care. The other component of the strategy is the Secretariat for Palliative and End-of-Life Care, and the Secretariat is housed in Health Canada. And the Secretariat consists of about 8 people. I think it's about between 7 or 8 people that look at coordinating activities related to palliative end-of-life care within the government. I've been reporting to Senator Carstairs, who will meet later this evening. But the Secretariat has set up 5 working groups. And these working groups include the one that Romayne leads, which is best practices. Help me out. Sorry, Dennie's got best practices. Romayne's got public awareness. Michael is involved, is a co-chair of the group on surveillance. Robin Cohen and Darren Hayland. Robin, I'm sure all of you know, is a very well-known psychologist, a palliative care researcher in Montreal. And she and Darren Hayland, who's an intensivist in Kingston, co-chair the group on research. And then Maurice Bouvet, who's a nurse in Ottawa, and myself co-chair the education working group. So the working groups are the surveillance, best practices, public awareness, research, and education. And so perhaps if we could just spend, say, 2 or 3 minutes, if you guys want to come up and just describe what your groups are doing. I think this is important because there are links with the Pallium as well. Romayne, do you want to come up and...
Our group is called Public Information and Awareness, and what we've been working on, we have 3 main objectives. One is to initiate a national campaign to get people to start talking about death and dying. And what we soon realized was that we needed probably $50 million really to do a real public campaign, but we could at least lay out the key messages and get a framework going. Here, I'm starting this word speak. Anyways, well, heaven forbid. We could at least get things going on that so that if we could get some, say, corporate partners or things like that, we could be able to do a campaign like Participaction. Can I tell you a bad joke? I wanted to change ours to Putrefaction. I thought that would suit our group. But anyways, never mind, sorry. And Mothers Against Drunk Driving and, things like that. So we're working on that. And what we're doing to sort of gauge where we're at now is we have working on our committee the Living Lessons project, which is funded through the GlaxoSmithKline Foundation, which is the employees of GlaxoSmithKline Pharmaceuticals have donated to this public awareness campaign called Living Lessons. And each year they do they have done in past times a poll. And we're about to do a poll again just before Christmas time, so don't hang up the phone if you get a call. Actually, you'd probably be excluded. But the questions we're asking about is how many people have done advanced care planning, how many people know what palliative care is, and I think last time they did it was 1997, and I think not very many people knew what palliative care is. But we're going to work on that, and we're going to ask how many people have used the services of palliative care to get some idea about who's using it and who has access and so on. And we've set ourselves a goal that, by 2008, either, a lot of Canadians will know more about palliative care, or we'll kill ourselves so we don't take any blame for it. No, that's not the case. So I'm forgetting this is being recorded. This is bad of me. Anyways, our second objective is we decided that someone had to be responsible for informal caregivers. That is not the professionals, but the family or identified family caregivers. So our group decided that we would do this. And what we're developing is an inventory of tools and resources for the informal caregiver. And we've had lots of debates over what to call the informal caregiver, you know, whether it's unpaid, paid, informal, formal, whatever. But you know what I mean. We're not talking about volunteers. They're in with the professional education. And our last but not least objective is to make a real forward direction in advanced care planning. And that is to be able to provide both professionals and the public with tools to help them understand what the process of advanced care planning is, and actually start to talk about this and have a goal of more people actually having gone through the process of advanced care planning. So those are our objectives, and as always, it's a bit of a battle between having all these great plans and having minimal funds to try and get things going.
When we met in Winnipeg, the different objectives and initiatives that were identified were categorized into the different working groups. Best practices and quality care is our official title, and we kind of got everything that was left over. And so, to some degree we did. But what we've really wanted to do or what we've been doing for the past year, and all the working groups have only been operating for the past year in a voluntary capacity. And so part of that year has been trying to discern what it is that we are doing. And my fellow co-chairs looked at us and said, we don't know what you're doing, and we're glad we're not doing it. Because best practice is a huge umbrella, and then throw in the quality care piece. So this past year, we have a phenomenal working group that's reflective of an interdisciplinary approach. And we've been looking at what are best practices, how do we approach this, considering the magnitude, and then we'll just throw in a little bit of the federal politics with that and how they influence the work that we're doing as well too, which actually had a phenomenal impact on all of us in terms of what do we prioritize in a given point in time. But what we have done, and I'm really proud, proud of our group. My co-chair is Lorianne O'Brien from Newfoundland. And our group has, one of the first things we've done was proclaimed or endorsed the CHPCA norms. The norms came out 2001, 2002, and 2002? And they've been distributed, but we've really wanted some strategies to actually have people endorse them, saying, yes, we will take this and have ownership and do something with it. It's to do something that's pretty gray, and so we're working with CHPCA on a project concept to move that forward. The next thing we wanted to do is to identify what are other people doing in best practices and what can this look like. And so we've been liaising with other groups, not necessarily within the palliative care community, about what are they doing and how are they looking at best practices, and finding that there's a lot of opportunities for partnerships so that we're not recreating the wheel, but also to really take some of the good things that are already being done within the healthcare sector. The next thing we've also done is to look at creating a shift, not looking at how do we develop best practices, because when you look at the domains, the 8 domains that are in the CHPCA norms, that's an evolving process in terms of what everybody's doing within their own practice settings. And so it's not our goal to actually define the best practices of all those domains, but to develop processes that people can choose to develop best practices within their own environments, and what could that look like. And so part of that is helping to create a shift within healthcare systems, and the initiative we're using to do that, and there has been an environmental readiness to do so, is to partner with the Canadian Council on Health Services Accreditation. We're acting as their advisory board to actually to look at 3 initiatives. One is to develop standards for CCHSA accreditation, And we just finished reviewing the first draft on Monday when we met together, and that's really exciting for those of you who've gone through accreditation to see hospice palliative care philosophy in accreditation standards. And I can't believe I'm excited about accreditation standards, but boy was I excited. The other strategy within the CCHSA initiative, which is brand new for them, is to do a feasibility study or feasibility proposal to look at what could standards, or is there an opportunity to develop standards for freestanding voluntary hospices. And so again, we're partnering with CHPCA and CCHSA to look at the feasibility of developing standards. We've just started that a particular proposal, but the initial response from volunteer freestanding hospices is they're welcoming the opportunity to have that discussion. We don't know where that's going to go, hence the feasibility intent of it. The third piece is looking at the existing accreditation standards, acute care, what else is there, cancer care, community care, continuing care, to see how is palliative care principles reflected in those particular standards, because we know that people die outside of the palliative care settings as well too. So those are the three pieces that we're working with CCHSA and are quite excited about that project. The other thing that our group is doing is we've got the volunteer piece, actually Romayne. It ended up, we've got it. And we've got Jerry, under the direction of Jerry Rothstein, who's well known from Victoria Hospice. He has a voluntary task group who have developed a framework for looking at what would volunteer standards and competencies look like in terms of the volunteer sector. And it has a 3-year plan for moving that forward, and they've been doing some phenomenal work in terms of bringing that forward. And Jerry has reminded us quite eloquently that his goal is that the volunteers receive up to, and even more so than 60 hours of volunteer training in hospice palliative care. He says his goal is that healthcare professionals will have the same someday, and which really helped to frame where the education initiatives could really focus on and what we could learn from our volunteers as well. So that's where we're at this point, given that we didn't know how long we'd be doing this for. My co-chairs don't know, but we learned on Monday the target date's now 2009. So we can do some more long-term planning in terms of looking at what can this look like in terms of best practices. When I looked at, we went through the information both Jose and Michael gave us. There's a lot of parallels in terms of what your visioning includes, in terms of what the working groups are doing or could be doing. I mean, when I see words such as clearinghouse, best practices, education of informal caregivers, my concern is that we as a palliative care community need to get our act together, because if we've got a bunch of different groups taking on similar initiatives that overlap, but we're not talking with each other, I think we'll be presenting some challenges that we don't need to have there. So I think there's certainly a lot of opportunities to have further discussion about how that could look.
One of the other committees is surveillance, and is probably it does have some short-range things, but it's probably a much longer-term process that has to unfold. So how in the length of the Pallium Project as it is now that surveillance process would connect is yet to be kind of explored.
Could you tell us what surveillance is first, for those of us
Yes.
that might not know?
Well, it's an interesting concept, like palliative care and end-of-life care. The surveillance, in just very simply, I guess, when we take our palliative population as we understand it and the ambiguity that we have right now in our definitions, when you try to say how can a government, a provincial health authority, a regional health authority determine policy and governments and implementing resources, they need to have data, they need to understand what the issues are, the costs are, and surveillance, on the one hand, in terms of performance indicators and things, will tend to try to provide that framework. For palliative care, it's quite daunting because it's not just cancer. It is, in fact, all diseases in Canada. It is all ages, from the young to the elderly. It is all settings of care, care in acute care, ICUs, home care, long-term care. And each of these, in each province, has its way of collecting data, of looking and analyzing. And so when you try to say what's happening in palliative care in Canada, what are the issues, you can't find it. It is extremely difficult. So this working group has quite an interesting and long-term task to try to build a system connecting a number of all of those areas, such that meaningful policy decisions can be looked at from demographics, from the way that palliative care would need to unfold. At the same level, there's another level in terms of programs. We would like to be able to compare clinical data, clinical issues, etc. That will have to take second place to the larger task of the initial kind of palliative data sets, palliative systems that need to be developed. There has been some work over the last number of years already done. Some of the people in the room here, Robin in Edmonton, the Halifax group, Toronto and others, there have been some work with Health Canada on developing a minimum data set. And we have moved from a study of about 8 programs done a few years ago to a broader survey of about 17 programs in Canada. That data is being analyzed now as kind of the looking at common types of indicators. In the short run, then, that piece, along with what's also happening right now, is a literature review, international literature review for performance indicators and surveillance in palliative care, is being analyzed and gathered right now. And we're going to take the Canadian stuff that we have, the literature review that we have. We are aiming in the spring to hold an international symposium of a number of people, key people such as Irene Higginson, perhaps from UK, and a number of national people to take a solid look then at where we are in Canada and what the evidence is and where we're going to go. So we have on the short range that kind of process coming forward. The longer range then is to try to build a way amongst provinces, jurisdictions, all of this stuff, to be able to collect that and analyze it over a period of time. And so the concept of a data warehouse at a national level is on the horizon, although a little further down. So we are working with Health Canada, CIHI, Stats Canada, and a number of palliative care programs to begin to look at that. There should be the resources. If we look at the hundreds and millions sitting in CIHI and the billions sitting in Canada Infoway and other things, there are huge amounts of technical dollar resources that reside in Canada unallocated. And it is like climbing Mount Everest, I think, to try to find ways of doing that, but that's part of the challenge of this group. So trying to make sense of palliative care from a data collection viewpoint is critical to some of the longer-term values and planning.
We work in the education working group, and the formal name of it is Education for Formal Caregivers, and that includes volunteers. Our committee is interdisciplinary. We've got representation. We've got a volunteer, Susan Dixon from Vancouver. We have a pharmacist, Pat Trozo from Winnipeg. We have a chaplain, theologian from Edmonton, Tom Maddox. We have a nurse from Sydney, Dale Orichuk. We have Maurice Bouvet, who's a nurse educator from Ottawa. And we've got another nurse educator from Montreal. The name just, it'll come. One of the great challenges we had was how can we represent a very large community across the country? Because there are a lot of educators across the country. How can we fairly represent the many ways and successful ways of doing things? And how can we do that without a very, very large committee that becomes too big and you end up just in a quagmire and mud, stuck in mud and not moving ahead? So we thought we'd identify 4 projects, and the aim of that project would be to bring input from across the country. And the 4 projects that we've identified are, 1, a survey of disciplines across the country looking at the undergraduate and postgraduate curriculum. What is out there in the nursing curriculum at the various medical school, nursing schools? What is the what's the palliative care, end-of-life care content in the curriculum of pharmacists, physicians, volunteers, etc.? So the first one is a survey. The second one is core competencies, is identifying core competencies related to palliative end-of-life care. And within that one, there are 2 areas. One is the core competencies that cross disciplines. And the other one is core competencies that are more specific to disciplines and also specific to specialties. Knowing full well that there are groups also developing it. And as Dennie said before, we shouldn't be duplicating stuff. So we're borrowing some work done by the society, by the committee for the undergraduate education of the Society of Canadian Palliative Care Physicians. The third project is the first education symposium in Canada for palliative and end-of-life care. And the symposium is going to occur on the 3rd to the 5th of June of next year in Montreal. It's going to be by and large by invitation, but I think it'll be quite big. It'll hopefully have the representation it should have. And the aim of that symposium is that we bring people together. It'll be the final step in the development of the competencies. We've got a process developed for the competencies to get input from across the country. It's not going to be just our committee developing the core competencies. And then we're going to test them out, we're having working groups across the country, etc., to develop those further. The fourth one, and probably the biggest of them all, and a lot of credit is owed to Senator Carstairs, is for a project that you're going to be hearing about. We can't formally announce it. The letter of intent has been accepted by Health Canada. The project is called FPEC. It's called Educating Future Physicians in End-of-Life Care.
Can you turn off the tape? I'm joking.
We've basically been asked to come to get together and, in collaboration with the Canadian Hospice and Palliative Care Association and the Association of Canadian Medical Colleges, to develop a project that's going to address the undergraduate curriculum and the postgraduate curriculum, so the different specialties across Canadian medical schools. So that's 16, soon to be 17 medical schools. The full proposal was submitted just a few days ago. There is input from the various stakeholders, including the Society of Canadian Palliative Care Physicians, the College of Family Physicians, the Royal College of Physicians and Surgeons, etc.